we go along. This is our second webinar for this week 5 on child health, and we are very pleased that Dr. Tintswalo Motimele has joined us from Frere Hospital, which is our large tertiary hospital here in the Eastern Cape. And she's going to focus tonight on a structured approach to the seriously ill child. And we recently have had, actually, when we were looking at one of our mortality meetings, and one of the big challenges with little children is children arriving very, very sick in our emergency rooms or in our wards. And quite often we don't have much time to make the right decisions. So Dr. Tintswalo has been working in pediatrics in a tertiary institution for the past 10 years now. And for 2.5 years before that, she worked in a rural district hospital in Limpopo, where she received training in Limpopo Initiative for Newborn Care, the LINC, and the Child Healthcare Problem Identification Program, the CHIP program, which I'm sure most of you are familiar with, before she moved to a tertiary institution. She also worked in Polokwane Provincial Hospital for 4 years before moving to East London Hospital Complex. She holds a diploma in pediatrics and child health and recently completed her fellowship in pediatrics. And we are very, very happy to have her on the call this evening. And welcome, Dr. Motimele. I'm going to stop sharing the screen and you can just share your slides now.
Good evening, everyone, and thank you for inviting me to do the talk with you. So I'm gonna start with a slide. Let's share.
Here we go, they're beautiful, I can see them.
Do I need to close the camera, sorry? Okay, so my presentation today is going to be on approach to seriously ill child. The reason why I want to present this topic to you is because I know we're facing challenges. I've worked in a district hospital. I know what we need, and sometimes we learn the hard way. So I think it will be useful if we did this talk. Can't move on to them, not sure why. Okay, so this is going to be the outline of my presentation. So I'm going to be focusing on the cases that present in casualty. So the first one is child with breathing difficulties, which we focus on airway and breathing, child with shock, fluid management, convulsing child, and then the approach to stabilization and transport. So the objectives of, and I just want to minimize this. The objectives of the topic is just to make sure that you understand the structured approach to the recognition of the seriously ill child. You need to identify and then treat immediate threats to life, which needs to be done immediately in order to avoid the mortality and morbidity later on. And then the intervention, and then also to introduce the equipment that is used for resuscitation of a seriously ill child and how to prepare for the transport of the child for a definitive care, which can be either in the ward or to another hospital. So with emergencies, usually they are recognized on arrival, which can be outpatient department or the casualty. Sometimes it can happen in the ward where you find that there are problems, but triage, it simply means sorting. So usually this is done by a nurse, a triage nurse who looks at the children as they arrive. The main aim or the objective is to identify very sick children who will benefit from immediate emergency care from those who should receive priority care. So these children are placed ahead of the normal queue. Those who can wait can be seen in the normal queue in order of arrival. So rapid examination of all children, when they arrive, it's done by the triage nurse, and then they place them according to categories. So these categories are the IMCI categories, and they should be assessed regularly as the categories can change over time. They can worsen and then maybe move to another categories. So as you can see, when they are in casualty or the OPD, you can see the long queue. The reason why I like this, you've got a long queue, you see the adults, and then there's a young lady with a small baby there. So of which when we look at the IMCI, we need to categorize and say who needs to be first on the queue. So category number 1 is we've got emergencies. So these ones, they cannot wait on the queue. Even if they arrived late, they can't wait, because by the time they get to the queue, we may have lost that chance to save them. And then there are those, the category 2 is priority signs, and then which are placed ahead of the normal queue. And then we've got the non-agent one, which can join the queue. So the priority signs that we need to look at to say now these ones we need to place ahead of the queue are babies who are less than 3 months, those with hypo or hypothermia, trauma cases, severe pallor, poisoning, severe pain, respiratory distress, any child with restlessness, continuously irritable or lethargic, urgent referral, it may be from a clinic or from a GP, malnutrition with visible wasting, edema of both feet, and major burns. So according to IMCI, so the categories are color-coded. So we've got the red ones, which are the immediate one. It's emergencies, they can't wait. So orange, we're saying these ones are priority, and then, but they need to be seen in less than 10 minutes. That's the target, of which it depends on how busy it is. And then there's a yellow one, and then they can be seen less, roughly about 60 minutes. So it depends on how busy it is, but the red one, you can't wait. So conditions that usually are red are if you've got a child with seizures and then burns on the face or inhalation, and then any child with hypoglycemia or those with severe pain, then they need to be seen. And then the other conditions then which are priority, then we'll also need to do continuous assessment as the categories can change over time. So with emergencies, what you need is a structured approach. This will help you to know what you need to do first, and then so that you're not disorganized or to miss some important signs. So first thing that we do is primary assessment. When you get there, that's what you need to do. You assess the child. Primary assessment entails the ABC. We always start with ABC. So it's airway, breathing, and circulation. So whatever that you find, if there are signs or something that is not normal within the range, then you have to do the resuscitation, which is number 2. Once you've done the resuscitation and stabilized, you need to do the secondary assessment, which entails history taking and then full examination of the child. And then with that, any signs or symptoms that you may find, and then you have to address them in emergency treatment. Once you've stabilized the child, you need to transfer for a definite care, which would be either the ward or refer to another hospital. So in terms of systemic approach, we've got A, B, C, D, and E. A, we look at the airway. B, it's breathing. C, it's circulation. D, it's disability. E, it's the exposure. So I would look at each of these in detail in the following slides. So airway and breathing. So first, the airway is when you have an emergency, you start with the airway. It's always the approach to say, is the airway, is the child breathing or not? So you look at the child. When they are lying where they are, do you see movement of the chest? Is there any abdominal movement? So you can tell whether they're breathing or not with that. If there isn't, they're not breathing. If there is, they are breathing, but you then need to look at what do I do next? So you can have a child who is crying or a child that is okay. When you find that, it means the child is breathing. So you move to say, now is the airway obstructed? Do they have an abnormal sound? Do they have stridor or do they have gargling, which you need to address? Each time you find an abnormal thing, then you need to address it. So, or else when you look at the child, are they having central cyanosis, which is showing severe hypoxia, since it's a late sign, or it may be due to an underlying cardiac condition. And then also severe respiratory distress. So airway, you've done the assessment. When you first look, the first one, are they breathing? If you find that the child is not breathing, so what you need to do is an airway opening maneuver. So we've got jaw thrust, With the jaw thrust, it's used in cases where you suspect spinal injury. So, and then the next one, it's head tilt, chin lift. So this one, you're doing it in order to open the airway. Once you've done that, you observe to see if there is any breathing or not, to say your method, was it effective or not. If they are not breathing, you need to give 2 rescue breaths. If they are breathing, we go back to assessing to say, is this breathing adequate or not? Are they having secretions that needs to be addressed? So if you find that you've got a child that is breathing, but maybe have secretions, and then you can say you put an oropharyngeal airway, and then it can be used in unconscious patients, but those who are at least having a GCS of more than 8, and then or very obtunded patient with no gag reflex. The problem is if they've got a gag reflex, they are going to vomit and then they will aspirate. So in terms of a size, then you can put the pharyngeal airway, and then the flange should be at the center of the central incisors, and then to the angle of the mandible. That's how you size it. Mostly in small babies, the color is blue. I know you can see the orange that is there. The problem with the size is that if you use one that is too small, it's going to be ineffective. And if it's too large, and then it may cause laryngospasm and then also cause a gag reflex, which we don't want. So this is just to say, at least you need to have an idea of what a normal respiratory rate is, because you've assessed then they are breathing. If they are breathing, are they having abnormal rate? Anything outside the range needs to be addressed. So if the breathing is too slow, it may be a terminal sign. If it's too high, we also need to address it to say, are they having an infection? But it may show that they are not yet tired of breathing. So once we've opened the airway, we need to check to say, what is the effort of breathing? So you look and then assess the child. Are they working very hard? Are they having severe recessions? When they are breathing, can you hear any abnormal sounds? So you also check with that to say, what are the signs of respiration in this case? If you've got a child who's got expiratory or inspiratory stridor, you need to address it, meaning that your next step will be to move and then you give the adrenaline nabs. Grunting is a very bad sign. It means the child is getting tired, and then you need to also make sure that you can give oxygen, or maybe at times you need to also intubate. And then the use of accessory muscles, head bobbing, you may usually see in a child who's sitting up, flaring of the nose, gasping. We don't want them to do that because we know it is terminal. So in terms of the effort, I've already mentioned the stridor, which shows the upper airway obstruction, and the common cause is croup, even though you can also get foreign body aspiration, which will present as that, but it's uncommon. Epiglottitis and bacterial tracheitis, neurotic edema, and trauma can also cause stridor, but it's rare. So if you find that you need to address it, if it's a foreign body, you need to be able to see if you can visualize, and then so you can remove. If you are unable to do that, don't force it. So phone in the ENTs and then ask if they are able to assist. So another thing that we need to look at is wheezing. We've opened the airway, child is breathing. Are they wheezing? If there's a wheeze, it means it's a lower airway obstruction. It could be a child who's asthmatic, or it could be an episodic acute viral wheeze that they're having. And then bronchiolitis can also cause a wheeze, even though some other chronic conditions can also cause wheezing, like cardiac failure or a child with cystic fibrosis. So with chronic lung disease, you can see that. And then grunting is usually caused by the expiration with partially closed glottis. We don't want that, it's a very bad sign. So the problem with oxygenation is that if they are not getting the perfusion very well, it affects other organs. So it affects the cardiovascular system, where you can get tachycardia. This is normally the early sign. Bradycardia, which is less than 60, we don't want it, it's pre-terminal. Then it means you need to act quickly. If you find a heart rate that is less than 60, you need to assist, meaning that you give cardiac massage. If there's no response to cardiac massage, then you have to move on to give adrenaline. So this will be stabilizing your child to say, now you want to save their life. Remember, we always have to start with the airway and then go to the breathing. And then look at the skin color. Are they having pallor? There's that pallor where you're saying now they are demising, and then there's the pallor where you're saying it's anemia. They also get the pale skin color because of the vasoconstriction. And then also cyanosis, that is a pre-terminal sign of hypoxia. Mental state with hypoxia, they get agitated and then they also get drowsy. So if you've got the child who's having breathing difficulties, you've tried the airway opening maneuvers and then it's not working, it means we need to do something else. So in this case, we're saying, okay, can be a child who's having inadequate, also involved. So, or maybe having cyanosis or bradycardia, we need to intubate. So intubation that we need to do, it's the indication. I've mentioned the involvement of other systems. Can be a child that you're saying that they are severely distressed, they will stop breathing. Children who are working very hard and then they are distressed, what they do at the end, they stop breathing altogether. And then you also need to look at the progressive deterioration, clinical condition, and then you also see the saturation that will be dropping, or you need very high FiO2 to maintain the oxygen saturation. And then for those that will be having blood gas, if you are lucky, or saturation, the captometer, then you'll be able to see that the carbon dioxide is increasing as well. So you need to intubate those ones. So one thing that I found confusing was the ET tube size. That's why I struggled when I was in a district hospital. But there are formulas that you can use to say this, at least you know. It will be better if you have it on your resuscitation trolley, whether it's in the pediatric ward or in the casualty department. There's a formula for children over 1 year of age. Uncuffed tube, you use the age, which will be in years, divided by 4, and then you add a 4. And then for a cuffed tube, we use age divided by 4 plus 3.5. That will tell you about the size of an ET tube that you need to use. In neonates, however, we know the newborn babies, the term babies, then we'll use a 3.0 or a 3.5 ET tube. If they're less than 3 kg, we use 2.5, 3 or 3.5 uncuffed tube. And then in terms of the length when you're intubating, it's the age over 2 plus 12 if you're doing an oral intubation. And then it will be age over 2 plus 15 for an intranasal intubation. So that one shows you how deep you need to go with the tube, because you will get the X-ray later. I know in the district hospital, there are no mobile X-rays. So that's why you need to check that at least you use that formula as a guideline. So I've got this video that shows the intubation procedure. So if you can have a look at
the patient well before starting. Intubation is accomplished in a smooth, coordinated sequence of alternating hand motions. To intubate, extend the head, but avoid hyperextension, which can obstruct the pediatric airway. Lift the blade with your left hand with the blade facing away from you. Insert the blade as far to the right side of the mouth as you can, and then sweep the tongue to the left. Control of the tongue is essential, or you won't have room to pass the tube. Slowly lift the mandible upward as you advance. Be careful to avoid pinching the lower lip between the teeth and the blade as you lift. Also avoid using the upper gum line or teeth as a lever, or you will break teeth. Continue to lift the mandible upward until you see the narrow epiglottis above, the bulges of the arytenoids at the bottom, and the vocal cord stretching between. Be gentle. Traumatic intubations can cause swelling, which can be especially dangerous in the child's small larynx. Use suction as needed. If you can't identify anatomy, then the blade may be in the esophagus. Often the larynx falls back into direct view as you slowly pull the blade back into position. Pick up the tube with your right hand. You can also ask your assistant to hand it to you in the correct orientation for insertion. Hold the pre-selected tube in your right hand like a pencil, curved forward. Keep your eyes on the trachea and maintain control of the blade. Insert it to the right side of the mouth and watch it pass through the vocal cords. Stop when you see the lowest marker ring past the cords. While there may be a blind spot at the moment of entering the larynx, you can often see the arytenoids behind the tube. Carefully remove your laryngoscope blade. Change to a smaller size if the tube won't pass easily. Forcing a tube can cause traumatic swelling. Children can't hold their breaths as long as an adult before the onset of hypoxia. If you have trouble intubating, stop and ventilate before trying again. Here we're looking at another straight blade intubation in a 5-year-old. See how the helper is pulling the cheek back to provide more room for the tube to pass.
Okay, so that was just a video showing the intubation procedure. So once you've intubated the patient, you need to verify the position of the ET tube. So the pulse oximeter will show you the saturation, which is what you'll be having in the district hospital. You can also see the misting of the ET tube, even though some say it's not a reliable sign, but you can also look at that. And then capnometer, we don't have it most of the time, but there are other hospitals which are having the capnometer. And then you also inspect once we've intubated and then giving the breath as the chest will start rising. And then the last thing that you do, you also auscultate laterally, and then also to exclude if the tube didn't go into the esophagus, because you will also hear the sounds when you're auscultating the epigastrium area. So airway and ventilation problem that you may face, once you've done the auscultation, and then sets may start dropping down, or you may not get adequate ventilation or perfusion that you're looking for. So you have to troubleshoot to check if maybe the tube is not displaced, if it's not obstructed, which is confirmed also with the chest X-ray, or if it's equipment failure, then it may also lead to ventilation problems. So once we're done with the airway, then you can secure the tube. But in a district hospital, once you've got a child that you intubated, it means they need to be transferred. That was to stabilize the child who didn't have any breathing efforts. So you intubated and then anticipating the problems. So you need to arrange for transfer for that patient. So that was A, B, and then now we have to move to circulation. With circulation, when you look at a child who may come in shock or any other problem, so you have to look at the heart rate to say, is it very fast, is it very slow, or is it a normal pulse rate? And then usually with early stages of shock, you'd get a normal pulse rate when they are still compensating. and then it may start normal, and then it starts becoming very high. And then later on, when they failed the compensation and then with no action being done, then it becomes very slow. They become very bradycardic. So that's a sign of shock. So which may mean that they may be in irreversible shock. And then pulse volume as well. You can get a pulse that is very, very weak. And then also capillary refill time. So you check on the older children, you can check the nail bed, and then the small ones you can check on the chest. So you press for 5 seconds, and then you release, and then you look at the time that it takes for the skin color to return to normal. Anything more than 3 seconds, we're saying they are in shock. So normal should be less than 2 seconds. And then also look at the blood pressure. Blood pressure may be normal when they're still in compensated shock, and then hypotension is a terminal sign. So when looking at the cardiovascular system and then also the circulation, we're saying it affects the other organs. So you can have the respiratory system where they will be tachypnic, and then with the skin, they get mottling, and then they've got cold peripheries, they're looking pale, and then mental state, because of the hypoxia, then they become agitated early on, and then they become drowsy. We also look at the urine output to say, do they have any or not? And in children, less than 1 ml per kg per hour, we're saying they're having oliguria, and then in infants, less than 2 ml per kg. Or sometimes at terminal stages, they can go to anuric phase, and then also check if there's cardiac failure. And then in terms of circulation, this is just an idea on what the heart rates are for children according to age. So you should be familiar with that. But if not, it's not a problem. You can always have a guideline with you. I don't know it, and I think sometimes it's difficult to learn them off by heart. So with the circulation, you can have a child that can present in shock. So shock is an acute life-threatening syndrome of circulatory dysfunction, which results in inadequate delivery of oxygen and other nutrients to meet the tissue metabolic demands. So shock can be due to different causes. It's not necessarily due to acute diarrhea that they may be having. There are other causes of shock. So there are different classifications of shock, and then according to the pathophysiology, or to say according to the etiology. Hypovolemia, which is the one that we mostly see, can be due to gastroenteritis, hemorrhage, intersusception, volvulus, burns, peritonitis. And then we can also have distributive shock, which could be secondary to septicemia, anaphylaxis, spinal cord injury, and vasodilating drugs. So, but the most that we see with distributive is the septicemic shock. And then cardiogenic shock could be heart problem, cardiomyopathy, we do see. And then they could also be having underlying cardiac conditions. And then we'll also have the obstructive, where it could be due to congenital cardiac disease like a coarctation, could be due to a tension pneumothorax or hemopneumothorax, flail chest in terms of patient presenting after a trauma or an accident, can have cardiac tamponade, and then pulmonary embolism. Dissociative shock we see in children who present with profound anemia, can be also secondary to carbon monoxide poisoning or methemoglobinemia. So signs of shock you need to be familiar with. I'm not going to go through this again, but you just need to realize that there are 3 different types of shock. You've got compensated, and then you've got uncompensated, and then the irreversible shock. With compensated, that's where you're saying they've got cold peripheries, they've got weak pulse pressure, decreased, but it's not more than 3 seconds. They are agitated, mild, mild confusion, and then they've got skin pallor. At this age, at this stage, they've got increased heart rate, but reduced urine output. But when they move to the other side, they may have no urine output. They have acidotic breathing, depressed cerebral state, and then prolonged capillary refill time. And then tachycardia, which later changes to bradycardia, less than 60. And then still with these two, you can try to get them back when you try. But once they get to irreversible shock, they go into multiple organ failure, which even if you do anything, then you won't succeed. But the best thing to prevent this is to get them when they're still in the compensated or uncompensated state, because once they get to that, and then it leads to death. So in terms of resuscitation, when you're saying you've got a child who's in shock, doesn't matter what kind of a shock it is, they need to get high flow oxygen by mask with the reservoir bag, intubate if they're having inadequate breathing, establish a venous or intra-osseous access. So we'll give normal saline bolus, which will be 20 mL per kg over 20 minutes. Once you've done that, you reassess to see the need for a repeat bolus or not. So get the blood samples, including the glucose, which you need to treat. And then in terms of suspected sepsis, and then you give ceftriaxone. I won't go into detail in terms of that since Dr. Tita has already covered that yesterday. So if you've got a child that is in shock, you've given a bolus, you've identified the problems, you need to refer the patient for inotropes. So IV line, then you can use the veins on the hands, on the arm, on the scalp, and then also on the dorsum of the feet. So this is the, once you fail the peripheral line, then what you need to do is to make sure that you access you do the intra-osseous line. I know you may not have the equipment sometimes, but you use the spinal needle to insert intra-osseous. That's the one thing that you can get, because most of the time you find people phoning and say they don't have, and of which is true, no intra-osseous needles that are found. So here I've got a video that shows insertion of an intra-osseous line using the needle, which will be adequate if you're in a district hospital.
Here today to talk about insertion of intra-osseous access in a child. Intra-osseous access is an emergency procedure to establish vascular access where conventional techniques fail. Before we start demonstrating the procedure, some equipment. Although there are many excellent commercial devices available for obtaining osseous access, these may not be available in the unit where you work. We will show you a technique today using an 18-gauge pediatric spinal needle with stylet, which should be available in most units. You will also need a selection of syringes. 10 ml syringes should be fine, and any drugs you require pre-drawn to the dose, which is weight appropriate. Although there is no one excellent way to secure intra-osseous access, we will show you one technique that uses an umbilical clamp, some tape, and cords. The first step when inserting an intra-osseous line in a child is to position the child correctly. The child should be on their back, with a blanket roll behind the knee to keep the leg gently flexed. The second step would be to identify the correct area of insertion. Grab the knee firmly and palpate for the proximal end of the tibia. The area that the intra-osseous access should be gained is about 1 finger breadth distal to that on the anteromedial flat surface of the tibia. Please take care not to insert the needle too close to the knee, as damage to the growth plate may ensue. Once the child is correctly positioned and the area of insertion has been identified, proceed with your procedure. Although this is an emergency and sterility is often not possible, attempt to be as clean as possible, and an alcohol swab clean of the leg is the absolute minimum. To use the 18-gauge intra-osseous needle, take off the sheath And we recommend holding it at the base of the index finger and then grabbing the needle between the index finger and thumb, giving you a firm but controlled grip. Once you have grasped the knee and identified the area for insertion, insert the needle through the skin perpendicular to the skin and bone. Once you have purchase on the cortex, in a firm but controlled manner, and in a twisting motion, insert the needle through the cortex. You will feel a give as it goes through. The tip of the needle should now be in the marrow space. Firmly grasp the needle and secure it to the skin and remove the style. One would often have spontaneous flush of blood into the needle at this time. If not, attach a needle to the end and just aspirate and see if you can see any blood back. Another way to confirm the back of the needle, infuse the fluid into the marrow space. Please note that there should be more resistance felt than with standard vascular access, but that excessive power should not be necessary. Once you have confirmed position, make sure with visual inspection that there is no extravasation of fluid, and palpate the calves on both ends to make sure that there is no extravasation into the posterior compartment. After the syringe has been removed, attach a three-way system and an extension set to the needle. At this point in time, you would connect your fluid and giving set to the three-way tap system and extension set. Please note that an assistant would now take over securing the needle. We recommend that you maintain manual control of the needle until such time as all the initial essential and life-saving drugs and fluids has been given, as securing the needle to the leg itself may actually cause dislodgement. Once an assistant has taken over here, attach your giving sets. It's very important to note that gravity alone is not enough to infuse fluid into the patient, and you would have to use a three-way tap bolus technique to do that. In order to do this, make sure that the tap is open to the syringe port and open to the intravenous fluid bag. Attach the needle to the port and aspirate the required amount of fluid from the bag. Now make sure that the system is open from the syringe to the patient and deliver the fluid as needed. This process can be repeated over and over, and the side port can also be used to deliver medicines. Once all initial life-saving medications has been delivered, securing the intra-osseous needle is an option. In order to demonstrate one technique for doing so, I will now remove the giving set from the back of the needle. But please note that when you're actually doing the procedure, you would not disconnect and have an extra assistant to help. All techniques for securing the needle to the patient's leg carry the risk of dislodging the needle or increasing vascular compartment pressures. One technique that has been described starts off with a roll of gauze that is placed against the skin at the base of the needle to protect the skin from any pressure. One could then take an umbilical clamp, press it down, and click in place. The final step would then be to use some tape to secure it to the patient. Do not use a lot of circumferential tape to secure the needle to the patient. It obscures the leg for visual inspection and the regular palpation of the calf compartment to prevent extravasation, and a constrictive circumferential bandage would increase vascular compartment pressures in the case of extravasation, increasing the risk of compartment syndrome. And that's it. Correct insertion of an intra-osseous line in a child.
So that was the insertion. In terms of that, you would have given your boluses. So you can give one bolus of 20 ml per kg, you reassess. If you need another one, you can repeat. So what we need to do is to say we've done well with our resuscitation, but we need to make sure that when they go to the ward or we send them wherever we are saying we're transferring, they need to be on fluids. Then we need to calculate the normal requirement. fluid for a child. If they are dehydrated, we have to add the extra according to the percentage of dehydration, which may be 5 or 10%. If it's 10% dehydration, then it will be 100 ml per kg. If it's 5, it will be 50 ml per kg, which will be added to the normal that you would have done with that. So how you would know the normal is that you've got the weight of the child. The first 10 kg, it's 100 ml per kg per day. The second 10 kg, it will be 50 ml per kg per day, and then subsequent kilograms, then it will be 20 ml per kg. Then you add this, and then it will be given over 24-hour period. This is for a normal well child, meaning that if you got a child, for normal maintenance, that's what you're going to give. So this fluid calculation just will simply show how you can calculate the fluids for the one that you're saying, either waiting for the transfer or you're admitting in the ward. So you've got a 16 kg child who's admitted with shock, dehydrated. So it means you'll give bolus. Once you have done that, you need to estimate the fluids that you're going to give. So we are saying it's 10% dehydrated, meaning it's going to be the 100 ml per kg that we're going to give plus daily maintenance. Remember, we're going to use the first 10 kg for this child, then it's 10 multiplied by 10, it will give us 100. It's 100 multiplied by 10, which will give us 1,000. Plus the second 10 kg, in this case, it's 6. So it will give us the 50 ml multiplied by 6, it will give us 300. So rehydration plus maintenance, you add them together, and then we divide over 24-hour period. That's what you're going to give. But you'll still need to continuously assess the child and then see what happens in order to say you want to reduce or increase the fluids. And then with the fluids, you also need to use the weight to say whether you're winning or not. If they are losing weight, it means the amount is not enough, then you may need to increase by 25%. If they get excessive weight gain, and then which you need to assess with other clinical signs like maybe edema, and then increased respiratory effort with crackles, and then also hepatomegaly, then you need to reduce the fluids by up to 50%. And then you can give oral maintenance. We want to change as soon as we can to oral, and then make sure they're tolerating. But if you assess, you find that they are still short, you may repeat the bolus, but then you would need to phone the hospital where there's an ICU, because once you've done that, and then they may end up in cardiac failure, so they will need inotropes. So this table, I'm not going to go through it. It's for acute gastroenteritis. If you can make sure you have it in your ward or also in the casualty department, just get it printed out, and then it gives you the direction in terms of how you are managing the fluids, whether you're reducing and then or you're increasing. So I'm done with the first C, but the other C that is also considered in casualty, it's febrile convulsions, or it's secondary to hypoglycemia. If you've got a convulsing child, it's an emergency. You need to make sure you manage them. So because with convulsion, they get into severe hypoxia, they are not perfused. So still with the same approach that we talked about, it say we also do primary assessment. Immediately we need ABC. We need to make sure we secure the airway. They are on the left lateral side, make sure there's a suction to suction any secretion they are having. For any child who has the convulsions, we need to give oxygen by face mask. If there's a hypoglycemia, you please check the glucose and treat it, because the seizure may not stop if you haven't treated the cause of the seizure. In terms of the hypoglycemia, Dr. Kit touched on that yesterday. I won't go much into detail with that. And then establish an IV line, because the main aim is to stop the convulsions. So we use anti-epileptic drug. So once you've done that, it's your primary assessment and resuscitation, then you can go to identifying and then treating the cause. as part of secondary assessment. So early stages, what you can give. If you don't have an IV line, they just arrive, you can give diazepam, which is given rectally 0.5 milligram per kg, or midazolam buccal, it can be given. So also IV, if you already have an IV, it's okay, you can give lorazepam, 0.1 milligram per kg. So once you've done that, you assess them and then to see what's happening after 5 minutes. But make sure you're maintaining the saturation and then also support the hemodynamic status. So between 5 and 30 minutes when they continue convulsing, can repeat the lorazepam, which will be 0.1 milligram per kg, and then you load with phenytoin or phenobab 20 ml per kg per day. So if you reassess after about 15 to 20 minutes. If they're still convulsing, it means you have to alternate. If you started with phenytoin, then it means the second one is phenobab. If you started with phenobab, then the repeat will be the other one. If the seizures are not stopping, it means they are in status epilepticus, then you need to phone the hospital with the ICU, and then so that the child can be ventilated and then started on midazolam infusion. So we go to the D. So our D focuses on disability to say, now is this child responding or anything like that. So what we do, neurology is always done after the ABCs. Always we start with the ABC. So the quick one that we use in the emergency department, we use the AVPU system. The A, it means they are alert. So we are happy the GCS is more than 13. And then the V, which is response to voice, means the GCS is about 12 to 13 or less. And then if they are unresponsive, it means they are unconscious. So Glasgow Coma Scale is also used, but where it's an emergency, the AVPU can be used. And please note that the lowest GCS is 3, not 0. Then management also will be based on that. Any child with GCS that is on this system P or U, they need to be intubated to protect the airway. So with a disability, you also have patients who are in coma. Once you've done, and then you're saying, now the U is unconscious. So it's coma. What could be the cause? There are different causes. And then the commonest one can be the hypoglycemia as a cause of coma and unresponsiveness. And then the one thing I needed to highlight with this is that once you give the bolus, you need to also make sure you continue the IV infusion of glucose to prevent the rebound hypoglycemia. So if you don't have the 10% glucose, then you just add the 20 mils of 50% to 100 mils of normal saline. Or if it's a half DD, because it's got 5%, you add 10 mils of 50% dextrose. We don't give the neat 50% dextrose, it damages the vessels. So hypoxia can also be a cause of a coma. We've already looked at the hypoxia when we're looking at the airway, and then shock. Also infection, she did mention yesterday about the infection. Trauma can also be another cause, but you need to make sure that the C-spine is also protected in order to prevent worsening of the neurological condition. So you give them high flow oxygen, nurse at 30 degrees head up, and then consider mannitol or 3% hypertonic saline. So, but these ones you need to, this hypertension can also be a cause. They can be having the post-rep glomerulonephritis with hypertensive crisis, they can coma, and then also seizures. And then sometimes which you think they might be post-ictal. Electrolyte abnormalities, they also cause a coma, especially the sodium. And then drug ingestion or poisoning we also have to look at. So another thing with disability, we also look at the posture to say, is it a decorticate posture or decerebrate posture? That may also guide us to where the insult is. If they've got brain injury, they may be having such posture. You look at the as well to see the size. If there is the E, it's the exposure. You have to expose, check if they've got rash or bruising. You can have rash in meningococcal meningitis. You can have bruising in cases where it's abuse, and then you see the child with where the family won't say anything, but you need to expose. The summary, that's what you do. Airway breathing. You look at the circulation, disability, and then the exposure. But the main thing is that approach. We do primary assessment to say, what is the problem now? Resuscitation. If you find a problem, then you resuscitate, which is the addressing the problem that you found. And then the secondary assessment, you get quick history, and then you do the systemic examination. Then you'll be able to have an idea to say, okay, this child is having this problem because they maybe, let's say it's shock, they had diarrhea, you know, maybe it's a cardiac patient, they're in cardiogenic shock with the history, you know. So emergency treatment, it means once you picked up the signs, when you're doing the secondary assessment, then you address them. So once you're done with that, you stabilize the patient, we're happy, so you can arrange for transfer. If you're happy, you can manage at the district level, it's fine, then you send to the ward, but make sure that you send them safely. You may not think that it's important to give oxygen from casualty or OPD to the ward, but it is. Even if it's a short distance, you do need that oxygen. They need to safely transfer the patient. But then how do you transport this patient? If you're saying now in your hospital, you can't manage the patient. So there is also an approach of the patient, which it's got an acronym, ACCEPT. So you have to assess, once you've done the secondary assessment, to say, okay, now I've got a child, it's shock, I've given the fluids, or maybe the airway was not open, I've intubated. I need to send the child. Control, it means you need somebody who will be helping you, calling in for the ambulance to transfer the patient. You need to communicate about the patient. So once you've done that, you also reassess your patient to see what's happening, and then in order for you to say, I need this in transit, then you prepare the patient and then the packaging in terms of the things that you're not gonna need as you transport the patient. And then you phone your transport. So where do you refer to? So hospitals which are along the N6 up to, when you're looking at your center point as East London, going to Aliwal towards Aliwal North, then they refer to Cecilia Makiwan. But the hospitals that are closer to Frontier Hospital, you transfer to Frontier first, and then if they can't manage, they transfer to Cecilia Makiwan. And then hospitals along the N2 to Butterworth, they have to, if you're around Butterworth, it's Butterworth, and then, or else then it's Frere Hospital. But then who do you call? So if it's during the day, you call the switchboard to ask for PEDS ward, you ask PEDS OPD, and then neonatal unit. So POPD during the day, they will be able to assist. If it's weekend, you just directly phone the doctor who's on call. So if it's a neonate, then you need to phone the neonatal unit and then discuss the patient, because they would know the bed situation in the ward. So also make sure you discuss with the receiving doctor, especially around 4, where other doctors will be leaving. And then the ambulance services, that's the number, 043 702 3000. Even though I must say that you have to be patient when you're calling the number, because sometimes it takes long for you to go through. And then in terms of communication, so you have your team that will be with you. It's always nicer to discuss with the seniors in your hospital. And then sometimes you can also discuss nurses that you are working with. You need to make sure you discuss with them, and then involve the child's family so that they know what's wrong with the child, why you are transferring the child. And then the transfer team, when you're phoning, you need to discuss, you tell them you've got a child with this problem, this is what you've given. So for the ambulance, you need to tell them the vital signs of the child, and then if the child will need fluids en route or they are intubated, and then also tell the family. the receiving team on the other side, you would have already phoned them before you phoned the transport. Because they will either accept or the elements in communication, you tell them who you are, your current problem, basically the summary of your findings on the patient, what you have done, if what you have done has had an effect or not. If you intubated but nothing has happened, you need to mention that. So then, but please intubate. So you do as asked to, because it helps. We know that the patient may complicate. And then you have to evaluate to saying, is the transport appropriate? So currently ambulance, but with that transport, you need to mention whether you need a paramedic or not. Because now you're saying we are transferring because the child needs special treatment, or they need special evaluation, or you need special facilities in terms of, let's say it's ICU, you don't have those facilities. So to mention what the clinical agency is. And then you prepare the child, make sure if they said intubate, you make sure everything is sorted so that the child travels safely. And then also equipment that they may need, maybe drugs or adrenaline, make sure it's safe, and then you get your ambulance. Currently, we are using the road transport. So your checklist for transportation, airway, you need to check that it's protected, and then the ventilation is satisfactory. Because if you're sending a child that is saturating between like 60 and so, then the child is not stable, may not reach where they are going. And then if it's trauma, you need to make sure that the neck is immobilized. Get oxygen. So even though most of the things that I mentioned here, it's for the transport to make sure that they have it, because you would have mentioned what the child needs en route. So, and then you make sure those things, they prepare them. Because if you say it's a transport, they don't know, they may not have the transport ventilator, and they will need to go back, which will take longer. And then you check the equipment as well. And then you just make sure, because sometimes it's handover between 4 or it's morning. And so just make sure that the patient is discussed with the receiving team, and then they are aware, and then you tell them about the time, or maybe when the ambulance leaves, you just inform them that now the ambulance is leaving, or ask someone else who can do that. Make sure when you're transporting the child, you've got the document. We need to know who the child is, just demographic details of the child, estimated weight, your notes, including what you have done, the neurological status and everything, so that we know that by the time the child was dead, this is what happened. If there are drugs given, if it's fluids, this is what's given. But you shouldn't take the records from the hospital, because those ones, they belong to the hospital. Just make sure that you write a summary, a transfer letter with those things. If there are any investigations, include them. Please also send through the x-rays, the film, we need them. Then you write your name and your phone number. Also write their name, and if we know who to contact. So you must always remember that the sick patients, they get sicker on transport. So make sure that you stabilize them before they go. And then longer transports, the sicker the patient will be. For example, with East London, you find that the patient is from Aliwal North. So it's going to take long, and the care en route, it won't be the same as if they're in the hospital. And then the sicker patients, they take longer to stabilize. So that's what you must know before you can send the patient. So keeping in touch, so you need to make sure that you hand over the patient to the transport team or the colleagues. So colleagues may be the ones who are taking over from you, or you're waiting, you arranged earlier, but you're knocking off, just hand over the patient. And then while the patient is there, you keep on reassessing to make sure if they are improving or they are worsening. And then call the receiving doctor if the patient is deteriorating. do not forget to notify the receiving team if the child dies before transport, because that helps in terms of saying we reserve a bed in ICU and then another child comes, but we don't admit because we are waiting for that child to arrive. So it helps in terms of managing other patients as well. So the references that you need to make sure that you keep in hand. So currently, what we're using is we've got the EML guideline that is online. So the online, what's good about it, any new information is updated. And then it's so helpful that doses, and it's got at the back, it's got a nice table on drugs and how to manage the electrolyte imbalance, the formulas they are there quickly. And then also the IMI booklet, it's helpful in the district hospital. So another book that you may not find is the advanced pediatric life support that I also used as part of the references. So that's all. I hope you'll be able to manage with the emergencies in your hospital. Thank you.
Well, thank you very, very much, Dr. Motimele. That was amazing amount of ground that we also covered in this hour, and I love the very practical videos. That intra-osseous line is one of those essential skills one has to pick up. I'm also going to be sending you guys around either tonight or tomorrow morning early the pediatric resource pack, and I'm going to put in links for some of those videos as well, specifically on that intra-osseous line, and also the IMC guide, all the links to all of those resources that Doc has mentioned as well. I'm going to launch just a quick poll and want to check if anybody has any questions. So you can either post your questions in the chat, or you can put your hand up, or you're welcome to even just put any comments. Or if you're struggling to chat or with your hand up, then you can just put in just unmute yourself. Great, and we're already getting lots of feedback. Thank you. The feedback also helps to just confirm who was on the call, so please do add your feedback. And the poll, Doc, is just to look at how useful people find the presentations, because it gives us an idea on if we've pitched at the right level. And yeah, there's some I can already see a lot of feedback here on how useful this presentation has been. There's in the chat here, let me just see, just a comment, especially that last bit about transferring the patient was awesome and extremely helpful. Thank you. So yeah, I think that's one of probably some of the most important skills we forget about when we're out in rural hospitals, is how to actually get the child safely from our hospital to one of the larger centers. So no other questions that are coming up. Doc, any last comments from your side?
No, I don't have any. So I hope all this information is helpful, but always they need to consult if there's anything they're unsure about, or maybe it's about the equipment. I think it's better to always discuss. There's no stupid question, because you always become stupid once, and then after that you will know the things that you needed. But it's life that we need to save. Thank you.
And I think sometimes we forget that in rural hospitals, that we always think we can only call our big central hospitals when we're actually sending somebody. But it's also fine to call a big hospital and say, listen, I've got this kid, I'm happy to try and manage them here, I just need a little bit of advice. And I find all of our referral doctors are usually very happy to give somebody advice and help them to manage a patient safely in that rural facility. So thank you very much, everybody. And thank you for, spending another evening to just in terms of next week on Monday night, I will be doing a presentation particularly on some advanced skills on managing stress, not only your own stress, but the stress of your colleagues as well as your patients. So we're going to look a little bit at what was traditionally called how to manage the patient who is difficult. We're going to take it a level up. So that's on Monday evening next week. And then on Wednesday evening, we're having Dr. Leslie Robertson, Prof. Leslie Robertson from Pretoria is going to be talking about managing the aggressive, psychotic patient in that emergency room setting and giving us some of the ins and outs in terms of how to manage those in our rural facilities. Good night, everybody. Have a lovely evening. I'm going to end the call here. And we look forward to seeing you guys next week, which will be our last week of rural onboarding.